speaker, Tsitsi Bandison, who's a statistician and clinical epidemiologist at the Biomedical Research and Training Institute in Zimbabwe. And she'll be speaking on moving towards targeted HIV testing in older children at risk of vertically transmitted HIV.
Okay. Good morning. I feel like I'm repeating Anjali's presentation because we are finding the same things. Anyway, I thank the organizers for this opportunity to present our study findings at this meeting. And this study was part of a bigger study that we're conducting in Harare among HIV-positive children. And there's some poster presentation which confirm a significant delay in HIV diagnosis. Just to give you a brief background, which is actually an echoing of the updated WHO fact sheet that was distributed on Sunday. It is acknowledged that the scale-up of comprehensive HIV and prevention and treatment services has resulted in the decline of the rate of new HIV infections. However, the global estimates indicate that over 60% of vertically HIV-infected infants remain undiagnosed. And these infants can survive without treatment for up to 16 years, but delayed diagnosis will be a cause of ill health and irreversible clinical complications later on in life. And for those children who have been diagnosed and are eligible for HIV treatment, we noted that the ART coverage for those under 15 lags behind that of adults, with global estimates currently stating at 24% in children as compared to 38% in adults. And in Zimbabwe, for the 2014 estimates, we had 55% of children on ART as compared to 63% of adults. In high HIV prevalence settings, WHO guidelines recommend that where an enabling environment is in place and adequate resources are available, and healthcare providers, the healthcare providers should recommend HIV testing to all patients in the health facilities, that is both public and private. This is regardless of whether the patient shows signs and symptoms of underlying HIV infection, and the main reason for doing this is to ensure early HIV diagnosis. And implementation of this has seen infant diagnosis being almost well established through PMTCT. However, the global target of universal coverage has not yet been reached in most countries, and with global estimates indicating that only 68% of mothers are receiving ARVs to prevent transmission. It is well documented that PITC has been faced with both provider and caregiver challenges. And the provider challenges include stockouts of HIV testing kits and pediatric drugs, the shortage of staff to conduct the testing, and exclusion of the adolescents because they are perceived to be low risk, and the general lack of confidence by the healthcare providers to provide HIV testing and counseling service to children. And on the caregiver side and patient level, there's an unwillingness by both the child and caregiver to have an HIV test, and also sometimes it's difficult to find a suitable guardian to give consent for the testing of the child. Anyway, the bottom line is a significant number of children remain untested, and resources are not adequate to test everyone. So why are we talking about targeted HIV screening? The current strategies of targeted PITs rely on the ability of a healthcare provider to identify risk factors of symptoms or symptoms of HIV, and this becomes a disservice to vertically infected children who can survive without any significant HIV-defining symptoms. However, we all know that there are screening algorithms with high sensitivity that have been used widely in resource-limited settings for infants at high risk of HIV. And we also know that the symptom screening have been used for other diseases like tuberculosis. Therefore, there is need to find a simple evidence-based screening method for potential mother-to-child HIV infection during routine care. And in this study, we looked at a proposed algorithm consisting of 5 simple questions, and anyone who responds positively to any of the 5 simple questions should be offered an HIV test. Therefore, the aim of this study was to validate the proposed screening algorithm and at the same sitting detect older children who would benefit from an immediate HIV test and treatment at the lowest patient and healthcare interaction level and allow early HIV detection and treatment. Our participants were children aged 6 to 15 years, attending 7 primary healthcare clinics located in Harare, Zimbabwe. And these clinics cater for a population of approximately 850 people, with 34% of them children being under 15 years. The primary healthcare clinics were chosen on the basis that they trained healthcare workers to test for HIV and to initiate ART. And where need be, we facilitated the training and added a study nurse and research assistant to assist. And for the children to be eligible for PITC, they needed not to have been tested within the last 6 months, be accompanied by an appropriate guardian, have verbal consent to an HIV test, and respond to all algorithm questions, which included having been admitted to hospital before, have recurring skin problems, and is a single or double orphan, and have been experienced poor health in the past 3 months. And the 5th question, which asked about STI, was not included in this assessment because it was deemed inappropriate for mother-to-child HIV infection. Now for the results. During the period of 2 years from 2013 to 2014, we screened over 20,000 children attending the clinics, and 12,000 were found to be eligible for PITC. And of these, 80% were tested for HIV, and of those who tested, almost all of them responded to the algorithm questions, and therefore approximately 9,600 were included in the validation of this algorithm. In this sample, nearly half of the participants were under 10 years, with a median age of 9 years, and approximately half of them were male. And 1 in 20 participants were found to be HIV positive. And just over a third of the participants responded positively to at least one of the screening questions. HIV positivity rate was high among those who responded positively to any of the screening questions. And as you can see here, 19% of those who said they had poor health in the last 3 months were HIV positive, as compared to 3% who said they were fine during that period. And also, not shown here, HIV positivity rate was not significantly different by gender, but children over 10 years had a significantly higher HIV positivity rate. And as expected, the higher the score, the higher the positivity rate. As seen here, 64% of those with a score of 4 were also HIV positive. We then looked at the sensitivity and specificity of the algorithm, and we found that the algorithm correctly identified 80% of children with HIV infection and 66% without. The positive predictive value was about 10% and was definitely affected by the prevalence of HIV, and the negative predictive value was 99%. And sensitivity was significantly higher in those aged over 10 years, but the specificity remained the same. And we also found that based on this algorithm, we would need to screen 11 to get 1 HIV positive. And because of the age variation of the sensitivity, we would need to screen more among those under 10 years than those over 10 years. So in conclusion, the performance of this algorithm would depend on the prevalence of each of the screening factors, and also the positive predictive value and the negative predictive value will be influenced by the prevalence of HIV in the target population. However, if the algorithm for screening older children at risk of HIV infection is used, it can identify over 80% of undiagnosed HIV positives. And since it's based on 4 simple questions, it is an attractive screening method which can be used by lower cadre health workers with primary health care facilities as the entry point. And we can also prioritize the limited resources by targeting adolescents with possible mother-to-child HIV transmission. And if we look at this study, only a third would have needed to be tested. So what have we been saying in the last few minutes? If a child is seen at the primary healthcare clinic that has been previously admitted to hospital, has recurring skin problem, is a single or double orphan, has experienced poor health in the past 3 months, we are suggesting that you offer an HIV test. And just before I leave, I would just like to thank the Zenith Project team and our collaborators, and the patients, the study participants, and their families, and of course, Wellcome Trust, who funded the study. Thank you.
Thank you. This paper is open for questions. So I have a question. Have you looked at this screen in other age groups, or was it developed specifically for this age?
When it was developed for the 10 to 19, but in this stage, we're validating for the 6 to 15-year age group specifically.
Do you intend to go further down as well to younger children?
We feel that the under 5s are being covered by PMTCT, so that's why we are targeting the older children at the moment.
Okay.
Thank you.
Okay.
Hello, Shannon Che from Baylor, Tanzania. A couple of questions. The first one is, what is your baseline prevalence, your background prevalence? So how did your 5% compare to your population as a whole? And then secondly, the questionnaire, was it well received by the healthcare workers, or did they see it as an additional thing that they had to do in their already very busy day? So what was your, I guess, the reception?
Okay. The baseline prevalence in the population was about 3% from previous studies that we have conducted. But for the other studies that we have conducted in clinics, it was as high as 10%. And in terms of the questionnaire, definitely yes, because of the shortage of staff, they sometimes see it as extra work. But we feel if it is part of routine care, it's easy, the questions are easy, and the nurses can do them, or even the counselors can ask the questions.
Thank you. I'm James Mikal from Kenya. The question is, amongst these children, did you find any reasons why they missed out to be tested earlier? Because that would be important to feed back into the PMTCT program.
Okay. This study, as I indicated at the beginning, is part of a bigger study that we are doing among HIV positives. And we are exploring those reasons why some of them did not come for HIV test earlier on that have been recruited in the study. So results will be coming out, and we have done qualitative studies, and some of them is mainly fear of the unknown. Yeah.
Last question.
Diana Dickinson from Botswana. Thank you for a very good presentation, and I thought that your algorithm was pretty good. But I have a problem, because with our Southern Africa prevalence of HIV, I think that anything that hinders access to a test is negative. And so I think that everybody actually should be tested. When they come to any medical, that's where I think routine testing comes into it. Even if you've got a sore toe, you should still get an HIV test. And I would really like to see every single kid with one documented negative or positive test, because I deal very often with children of 15, 16, 17, even 23 who've been diagnosed for the very first time mother-to-child transmission. And it's terribly, terribly destructive to self-esteem and to the way these kids, their whole life just falls apart. And so for me, I think routine testing for every single person in Southern Africa. Because
okay, thank you. I think your point is well taken. Thanks. Okay. We're going to thank you very much.
Okay. I think that's quite true. That's the ideal situation that we're all looking for. But as I indicated in my introduction, despite that we have got this ideal situation, the reality is that we don't have the testing kits and the resources to test everyone. That's why we are moving towards targeted testing, so that we can kind of reduce the numbers that we are testing. It's like, for example, example, in our study, it's like we had shortage of testing kits some of the times, and because they were prioritizing ANC,